Hey there, everybody, and good evening. Top of the Tuesday to you, and it is great to be back with you. You are on Fertility with Fink. I am Fink, and this is the place to be. It is 5 o'clock on the Gulf Coast, which means 6 o'clock in the East, 4 o'clock in the mountains, and three on the West. And this is what we do every week at this time. It's Fertility with Fink, where we can talk about all those things that are important to us in terms of making babies, in terms of getting pregnant, in terms of just generally all those things about women's health that are important to us. And it's so nice to be here. I have to tell you, I was out last week. Last week was a sick week for me, and boy, was I sick. Oh my gosh, I wanted to do everything that I could do to try to be here. But man, I had a fever of 102 and my pulse was 160. And oh boy, it was just awful. Could barely move. So, it's kind of a big thing if I can't make it to Fertility with Fink. So sorry I wasn't here, but thanks for all the warm wishes that got sent my way. Thank you to everybody who said, hope that you're feeling better. And I do. And here we are. You may know, well, actually, we're lucky enough here that on this program, we appeal to folks all over this great nation of ours. My primary office here is in Pensacola, Florida. We also have an office in Panama City and in Mobile, Alabama, which is New Life Fertility, or New Leaders in Fertility and Endocrinology. But I also work with my dear friends at the Missouri Center for Reproductive Medicine, MCRM, in St. Louis and in Tulsa. And in fact, I will be there this coming weekend, traveling actually Wednesday, and I'll be doing retrievals there Thursday, Friday, and Saturday. So if you are in the neighborhood, please stop by to say hello. You may notice the jewelry here, the accoutrements, and as Marlena added, yep, happy Mardi Gras. Today is Fat Tuesday. So as I started to say, if you're from the area here, most people know that this is Mardi Gras Day. But if you're from outside the Gulf Coast, you may not realize what an important and significant holiday this is, with all the parades and the beads and the partying and the good times and everything else. So happy Mardi Gras, happy Fat Tuesday to everyone. And, it's an amazing thing. I remember, from being in New Orleans on Mardi Gras evening, Mardi Gras night at 12 o'clock, at the end of Mardi Gras, the police line up on horseback on Bourbon Street, and, all in kind of one big line, and they just, kind of push everybody down. And that is the official sign that Mardi Gras is over. So until then, revel, enjoy. Happy Mardi Gras to everybody. Let's see who we have here with us. The most famous VIP guest of all is the Bama Gal in Mobile. That is Mr. and Mrs. Fink, my parents, who happily are able to watch most Tuesdays when they can figure out how to get the internet on. So thank you so much for being here. Good evening. Hi, Midgie. It's great to see you here tonight. That's Midgie 56. We have Indepino Journey. Rosa, thank you very much for the kind words. Hi, hello to Ocean. And let's see, Mrs. C.R. Tyler. You were there. Rosa, you're actually the first to join over here. Sheila 125 is with us over on the New Life side. So we've got New Life's Instagram here. We've got my Instagram, that's Randy Fink MD. We've got Facebook and YouTube and LinkedIn for both New Life and myself, and for the First Fertility Network. So we at New Life Fertility and at MCRM are part of the world-renowned First Fertility Network, and I'm very proud to be a part of that organization. So if you've got some questions, throw them my way. I am happy to get to them tonight, and I hope everybody is doing well. I hope your Valentine's, more importantly, was an excellent evening for everyone. I also want to throw a very special shout out this evening to my friend, Dr. John Wigg. Dr. Wigg, despite what everyone says about you, I think you're a pretty decent guy. pretty decent, but we'll leave it at that. So, Dr. Wig, thanks for being who you are. And frankly, I'm sorry you are who you are, but thanks anyway. Rosa asks me, how often do you see in your practice that an endometriosis cyst in the ovary gets smaller after breastfeeding? Mine is still around same size after about 3.5 months of breastfeeding. Any hope it gets smaller later? I doubt it. I doubt it. So, breastfeeding has a suppressive effect on the hormones, and it's the hormones that can feed endometriosis. And sometimes, even after pregnancy, we might find that the endometriosis itself has gotten smaller. And I think that was the situation for you, Rosa, that your endometrioma, if I remember correctly, was about 5 centimeters or so. I think you've told us. And the fact that it got smaller, I think, is a great thing. But how likely is it to go away? Not very common, unfortunately, that it goes away. But it kind of begs a great question. How does endometriosis get into the ovaries anyway? So there's some different theories as to how endometriosis comes to be. Some people think that it has to do with your lymphatic system, with lymph nodes and lymph glands, that endometriosis is transported through that system up into the pelvis and in other places. Others think that it may be more likely that it happens as a result of the fact of menstrual flow, instead of working its way out when we have a period, that it goes backwards. So it's what we would call retrograde flow of menses that gets into the pelvis, gets onto the ovaries, and gets into the pelvic peritoneum. That's the lining of the abdominal cavity, and ultimately then sticks and starts to grow. So when it implants on an ovary, so imagine it's coming through the tube and it sits onto an ovary right here. Well, the ovary tries to start to build itself around that endometriosis, and that is what creates an endometriosis cyst, or also known as an endometrioma. Why does endometriosis matter? Well, endometriosis matters because it can affect us in many ways. So the classic presentation of endometriosis is someone who has a pain syndrome. It often is the most common cause of severe pelvic pain. But believe it or not, so that's the classic presentation, but the most common presentation is actually silent endometriosis, and that's people who would otherwise not know that they have it. So it can affect things hormonally. It can affect ovarian reserve. It can affect things mechanically, like causing some scarring on the inside. But really what we know now is that endometriosis also causes an issue with the way your embryo implants inside the uterine cavity. It affects the way embryos implant. And we can now test for this without doing surgery. So previously, the only way to know that you had endometriosis was to have a laparoscopic surgery where we place a camera in through the belly button and look around and actually see the endometriosis. Now, through a simple endometrial biopsy, which is a test known as receptiva, we can determine the presence of a marker that's known as BCL6. And I just saw here Marlena is asking a question about that very test, receptiva. She says, what cycle day or part of the cycle is the receptiva test done? Well, Marlena, it's done at the time that your embryo would otherwise be implanting. And that's about 7 to 10 days after your ovulation. Or if you don't ovulate, if you do it with a mock cycle or a medicated cycle, you would use typically a couple of weeks of estrogen followed by 7 to 10 days of progesterone. And sometime during that 7 to 10 days of progesterone, that's when you would do the test. So the test is only validated during that specific time and should not be performed at any other time of the cycle. We used to say, well, gosh, we're going to try to perform this test maybe when you have your egg retrieval, because that's going to save you some trouble. You're already there. You're under anesthesia, so you don't have to feel it. It's all a really good thing, right? But the test is not validated in that time frame. You really have to have a lining of the uterus that is consistent with the timing that you would otherwise be implanting your pregnancy. That's the time that we want to test for that BCL6 marker. What we think BCL6 does is that it opposes your progesterone. And when it opposes your progesterone, progesterone is the most important hormone that your body needs in order to maintain a pregnancy. So if you're blocking your own progesterone, your pregnancy may not be able to implant. So that's the whole purpose of the Receptiva test and the BCL6 test. And that's the significance really of the endometriosis. So going back to Rosa's initial question, well, when you have that collection of endometriosis in the ovary, we know that you have endometriosis. And so I would say in that scenario, is it worth doing the test for BCL6? And I'd say, I don't think so, because the point of doing the BCL6 marker test is to determine whether you have endometriosis. And if I can look with an ultrasound and see it all built up in your ovary there, guess what? You have endometriosis. And so therefore I would just treat it appropriately. So that's the story there. A special hello to Sharmila this evening, who, gosh, your baby is 6 months old and started solids. You know, remember, Sharmila, when that baby of yours was just a flicker in your eye and just a dream that we had together, just a hope, just a mere dream, and how quickly that dream comes true. And I think, as you're going to see, because gosh, in my mind, she was born just yesterday. She's already 6 months old. Time goes by so fast, but I am so happy for you, and really am just overjoyed for you and your family. Hey to Liz. Indipino asks, what do you think about Clomid and 300 of Menopur protocol after a canceled cycle? So usually when we cancel a cycle of IVF, we are doing that because you didn't get a great response to the medication. And so we'll cancel if the follicles just aren't growing, because we don't want to have to put you through an egg retrieval if there's really not going to be much, if anything, to retrieve. So when you add Clomid to a stim cycle, we're often doing that as kind of a last ditch effort to see if we can get the ovaries to respond. And when you do Clomid, sometimes they will respond when they haven't so much responded before. And in fact, you just kind of gave me a good idea for somebody that I was just thinking about, because Clomid we often overlook. Clomid and 300 of Menopur is a reasonable thing to do, because usually what we want to do is if we're using Clomid for a cycle in someone we will call a poor responder, we dial down the stimulation in order to try to dial up a response. And that may seem counterintuitive, but sometimes these very high doses result in a stimulation that just doesn't produce anything, because it may be that the ovaries, they don't know what to do with all that stimulation. So I do think that's a reasonable and recognized approach to people who have not responded as well as we had hoped. Now, I got to tell you, I'm very excited about a medication that I am using more and more now, and we've talked about it a little bit before, but the medication is called sirolimus, or also known as rapamycin. If you do a little Google search for rapamycin and IVF, it depends on when you're looking because the older data used higher doses of rapamycin and found that, well, you know what, it actually had it lowered outcomes. But there's some recent data, actually human data, looking at studies of, in the hundreds of people, not in the thousands, but in the hundreds of people, where low doses in short durations, like 30 days. So I typically start 21 days before the onset of stimulation and continue it until the day before egg retrieval, has been associated with improving egg quality, increasing the number of high-grade embryos, and actually improving the live birth rate as well. The other nice thing about this medication is that it's really inexpensive. So compare that to what we, classically have used, which is growth hormone. So growth hormone is very controversial in IVF. It's kind of been the only thing that we've been able to give to people in order to try to elicit a response, try to get a response when responses are hard to come by. We've been hoping that a little bit of some growth hormone, because growth hormone is what keeps us young, maybe it has the ability to help us to correct some of our age-damaged DNA. But there are some studies that show it really doesn't do anything except increase the cost. And increase the cost, it certainly does, because it's a very expensive medication. From the fertility specialty pharmacies, it usually costs about $700, I think $700 or so. If you took that same prescription into like Walgreens, $5,000 is what it costs for some growth hormone. So, it can be very expensive. Whereas the rapamycin dose for that 30 days, oftentimes is covered by insurance. But if not, with a GoodRx coupon, it's like $40. So not expensive at all, and really seems to be making a difference, and is backed by some small studies, but impressive studies. And I can say I'm starting to see the difference with it in my practice. So to me, it's exciting. Some hellos out there to Florida Gator Girl and Deanna, nice to see you this evening. Shelby, hey there. And Katie be doing things. Hey to Sarah, also on the New Life side over here. My friends at MCRM Fertility are kind enough to say they are looking forward to seeing me, and I am so much looking forward to seeing you. Such a beautiful practice there in St. Louis and in Tulsa, full of really wonderful people, really caring people, really folks who are just very aligned to make magic happen. And it's such an honor and a privilege to be able to be a part of that organization. Hi to Mallory. What dosage protocols are in place for donors to not overstimulate and not to become over responders? Well, so you do have to typically be careful with that, because eggs that are produced in a hyper-stimulated environment may not perform as well as eggs that are produced in a non-hyper-stimulated environment. And what do I mean by that? Well, usually what happens, Mallory, is that we want to just dial down the doses, because most of the folks who are egg donors are young and will typically respond well to the hormonal stimulation. So they often have a little higher AMH level, which means that they are known to be, or we expect that they will be good responders to the medication. So dialing it down is important, because on the one hand, we could do an egg retrieval on a donor, let's say, who is maybe 23 years old, has a high AMH. And I know if I give her a lot of stimulation, I can make her ovaries that are normally the size of, let's say, walnuts, easily become the size of coconuts or cantaloupes, or maybe even small watermelons. And I may be able to get, 120. I think my back at my former employer, the largest number of eggs I've ever retrieved from someone, I think, was about 140. And to be honest with you, that's way too many eggs. That's way too many eggs. So that creates 140 eggs that then wherever those eggs are going, can be sold to someone who is purchasing donor eggs. And so you say, oh, well, more eggs, more the merrier. But that's not true, because in that hyperstimulation setting, your body is really focusing on quantity over quality. It's not more eggs are better, because more than about, let's call it 15 to 20 eggs in a given cycle really don't start to improve outcomes. So that's kind of where I'm looking for. So we really just kind of want to dial it down. But that's a great question, Mallory. Very intelligent question there. Thank you for that. Miss C.R. Tyler says, I keep missing out on a lot of follicles that aren't growing large enough to sink for retrieval. I've heard good things about a luteal phase stem for this situation. What are your thoughts? So a luteal phase stem means that you start a stimulation in the second half of your cycle. So we always think, right, about a menstrual cycle that is, okay, you get your period, call it 14 days later, you release an egg, and then 14 days after that, you get another period, right? That's a standard cycle. The first half of that menstrual cycle is called the proliferative phase. The second half of that menstrual cycle is called the luteal phase. Well, a luteal phase start is when we start in the second half of the cycle. So we like to do it in the beginning because we know that, well, it's going to kind of be predictable the way it's going to work. But believe it or not, there are actually two phases of egg recruitment in a cycle: in the beginning and in the middle. So that may be a scenario, Mrs. CR, that might work in that situation, especially if you've got, so luteal phase stems, I will think about doing sometimes for people who are poor responders, but especially if you've got a whole bunch of eggs and you're not really getting, you're getting a bunch of follicles and you're getting a few eggs and you got a whole lot of follicles, then it may mean that the second half of the cycle might be a better time to start. Yep. So you're absolutely right. That's called a luteal phase start. Now, there's another way to look at that, and that's doing something that's called a duostem. And a duostem is different. Now, your doc may talk to you about a duostem because there are some practices that like to do duostems. And what a duostem is you do your first retrieval, a standard retrieval, which ends up being, around, call it roughly day 14 or so of your cycle. You give it 3 or 4 days off, and then you start your next stem right away. And starting that next stem right away, that's what's called a duostem. And that's something that sometimes we'll do for folks, let's say for cancer patients, folks who have a hard stop, a time at which, they're going to be starting their chemotherapy on such and such a day, and we have to get as many eggs as we can get from them as quickly as we can get them. And so we may do a duostem, and that's really what it's intended for. In a normal responder, a duostem will typically get you fewer eggs. In a poor responder, it may be helpful, but in a normal responder, I don't recommend that kind of approach. But starting from scratch at the middle of the cycle is what we're talking about, is what I'm thinking of when you're asking about that luteal phase stem. So yeah, great question there. Now we got good questions tonight. Carranza family, good evening and welcome. Glad to have you guys. The Daver Lee, hello there. Dr. It looks like, Dragonmeyer. Hi, Pui, nice to see you. Haven't seen you around for a while. Be back in your neighborhood soon. Dragonmeyer says luteal estrogen patch priming, or add 3 doses of ganirelix to the estrogen priming before an IVF cycle. So I think you're asking about which is a better way. I'm not sure if you're providing advice for somebody there or if you're asking a question, but yep, the typical way to do estrogen priming is to do some estradiol either in the form of a patch or in the form of a pill in the luteal phase, usually for about 10 to 12 days before starting the next stimulation. So that's usually what I recommend. Mrs. V, great to see you as well. The Villarreal family is here. I had my baselines at 8 follicles on the left and 34 on my right. Did you say 34? Holy cow. Wow. I've been on Omnitrope for about 5 months. Can it be that or my PCOS? Is that abnormal or can it be a good thing? Well, when somebody tells me that you have 34 antral follicles, to me, that is by definition what we call PCO morphology, polycystic ovarian morphology. Morphology just means the way something looks. And so the ultrasound criteria is typically if there are 12 or more follicles in an ovary, that is considered to be PCO morphology. So what Omnitrope does is that Omnitrope, we're trying to improve egg quality with Omnitrope, but really the number of eggs that you have in your ovaries is there from the day that you're born. So I wouldn't expect a medication to necessarily change the appearance of the number of eggs, but rather the quality of those eggs. So I'd have to say that you, my friend, are definitely an ovary achiever. 34 follicles on your right. Gosh, that means that absolutely means that you're going to have right-handed babies. That is the only possible explanation for that, just so you know. I'm just kidding there. Marjorie asked, what are some of the long-term side effects with egg retrieval if complications arise, such as pelvic fluid due to a hyperresponse? Well, so what you're talking about is called ovarian hyperstimulation syndrome, OHSS. And the whole goal with IVF is to do what's known as controlled ovarian hyperstimulation, or COH. So we're trying to hyperstimulate you to some degree, but not to the point where it's going to cause problems. So on the one hand, we want to maximize the number of eggs. And physiologically, you're probably only releasing one egg in a given cycle, right? So that's why we talk about controlled ovarian hyperstimulation. Level 1 OHSS just means folks have some discomfort. The ovaries are larger than they normally are. There's typically some bloating. Your bowels may slow down. You may find that you're a little constipated. So almost everybody has some degree of that after stimulation with IVF. The issue starts to come when the hormones associated with all those follicles that have been stimulated are making too much estrogen and are making too much of a chemical in the body that starts to make your blood vessels get leaky. And those leaky blood vessels start to allow fluid to accumulate in places where fluid is usually not. So that may be in the belly, and that's what we call ascites. Ascites is that it's a proteinaceous type, clear, usually straw-colored fluid, sometimes it's bloody, that collects in the pelvis and is associated with ovarian hyperstimulation. Now, it's very common. Many people at the time of an egg retrieval have a little bit of extra fluid in there, and that just happens. And it can even happen naturally without stimulation, that you can develop a little ascites. The problem is when that ascites becomes very significant. So sometimes we can do a procedure to remove all that extra fluid, but sometimes that amount of extra fluid, it can be, liters of fluid that you have on the inside. And that's problematic because if you're leaking that much fluid into your belly, there is a possibility that you're also leaking it into what we call your interstitium. Maybe you've got real swollen ankles and swollen fingers. Your rings don't fit. But moreover than that, all that's making your heart work harder, and you can even get some of that edema, some of that swelling in the brain. So it can start to cause electrolyte problems in your body. It can cause liver issues, kidney issues, and ultimately can affect the brain. In the olden days, before we really knew how to treat, which is really to prevent ovarian hyperstimulation syndrome, it would not be uncommon that every week that we would doing retrieval, somebody would be in the ICU with OHSS. In the olden days, I'm told that people were routinely in comas. And I don't know that have never experienced that myself, because really we've reached a point where we understand what causes OHSS and how we can treat you differently to avoid the very severe type of ovarian hyperstimulation syndrome that some people can get. So that severe type of thing should never happen. The best way to treat it is to not let it get there. There's really very little excuse for that severity of OHSS in my view. But as far as long-term side effects, fortunately, people recover from it. We even do know how to treat it when we get to, if it gets that far or people start to get sick from it. If it happened to you where I used to work, it was not uncommon to have people that we would have to hospitalize as a result of OHSS, because some people's bodies, we were doing a very high volume of IVF. So some people would respond very, very well and would slip through and could, easily get quite sick from it. But I would not expect for people to be in the ICU. I would not expect for people to be in a coma anymore. These are the kinds of things that we really ought to be able to prevent. Mallory, hopefully that is not what happened to you. Drop me a note there if it was. Hey folks, guess what time it is? It's 32 after the hour, and so and there's something I like to do every week, and I call it the 5:30 because I'm in the Central Time Zone here. But the 5:30 fuzzies with Fink. And what are the fuzzies with Fink? This whole fertility journey can be a very lonely journey. It can make you feel like you're very much alone. It can be very, very frightening. And I like to think of it as, it's a crappy roller coaster to be on, because it's jerking you around, it's spinning you upside down, it's making you nauseated, it's giving you a concussion, it's uncomfortable, and it's scary. You don't know if you're going to fall off, and more importantly, you don't really know when you pull into the station if you're going to be able to get off that train with a baby, which is really why we're doing this whole thing. It's an uncertainty, and that uncertainty really leads to discomfort and feelings of loneliness. So at the 5:30 Fuzzies with Fink, I like us all to take a moment to really understand that we are not alone. Most of the folks who watch my podcast here are the kind of people who would literally reach out their hand to anyone who is in need, who is going through some of the same things that they're going through. And while we can't, I used to try to go through and mention everybody's name who was on here or who was watching. It gets kind of hard to do that. But I just want to say, if we can take a moment and send out all the good vibes that we have tonight, right now, and stand together as a community, I think we can break the internet and really send a lot of good out into the world, not just for folks who are dealing with fertility concerns, but dealing with family matters, dealing with relationship issues, dealing with school problems and work. No matter how alone you feel, you are not alone, because we are all in this together, and that there is hope Every day should be led with hope, because tomorrow, as I close the show with every day, I will tell you tomorrow is a new day full of all new adventures. So please send those positive vibes out right now to everybody who needs it. You are not alone, my friends. We are all in this world together. So thank you. That's the 5:30 Fuzzies with Fink. Actually, we'll call it the 5:34 Fuzzies with Fink at this time. But every week I try to do this. If you wouldn't mind, get all your friends to join, even if it's 2 minutes before the half past the hour. So I think the more happiness we have here, and the more we can share these positive vibes out there, really the better a world we'll be able to live in. And the world's a tough place right now. All you have to do is spend a little time on television, watching the news, and you'll see that. Jessica Val, good evening. And my friend Angela. Hi, Angela. It's great to see you. And thank you for your kind words when I was sick. And a special happy Tuesday and happy Mardi Gras to Zenny down in Miami, and as well as Chrissy Florals and E. Romero. Howdy. The Foxy Angelina, thank you for being here. Oh gosh, E. Romero says you did our transfer in 2023, and now our little guy is almost 2. Boy, man, the time just flies away, and I think that is, it's amazing. It is absolutely amazing. IUI and IVF mamas, what an honor to have you here. Thank you. Angela asks, can you have an SIS, a saline sonogram, in the same cycle as you do an embryo transfer? I don't recommend it. In my opinion, we really try to avoid doing anything that's going to be touching that uterine lining when we intend to place an embryo inside. Now, there have been situations where we can do a little hysteroscopy, place a little camera just up to the opening, float a little fluid around there. Is that substantially different than doing a saline sonogram? I suppose if you have to, you could. But would you want to? My answer would be no. If you were my sister, Angela, I'd say no, don't do that, because, these embryos you've made, these are highly prized embryos. They are really little bits of magic there. So we want to give them every opportunity we can to be in a perfect environment. And so I do think it's important to test that environment. And that is a good reason to do a saline sono. You want to make sure that cavity is normal. But I'd really rather not be touching those cells in the cycle when that perfect little embryo is going to go inside. You know what I mean? That's my opinion. Other people may have a different opinion, but that's sort of the way that I was trained. Sweaters for IVF, good evening. And Ob Fraley, Mrs. V, yes, praying for all us ladies. Thank you for that. Those prayers really make a difference. Baby dust and positive energy to everyone. Hello, Shabnam. Nice to see you this evening. Positive vibes. Oh gosh, Rosa says nice things. Your sending positive vibes helped me a lot during the process. And you know what? I think it really does make a difference just to know that you're not alone out there. I'm here for you every Tuesday. And like I say, I think that every single person who watches this show would probably bend over backwards for somebody else if they knew that somebody else needed to know that you've been through it too. And again, it's everything in our world now, not just fertility. But so thank you guys for sharing that positive energy. Remember, everyone, we are more than just moms or moms to be. We bring much to the world and make a difference just in living our lives. E. Romero, boy, those words could not be more important. And I think I am going to share that next week, and I will give you credit where credit is due, because that's very, very true. And, it's kind of the way, I went to a psychic once, and this was a very long time ago. And we can talk about psychics and things because I have beliefs that there are people who are truly, gifted. But this was, probably I may have been 23, 24 years old. I was very young, and even at that point, I had graduated from college. I was working. I was not yet, or maybe it was just before I started medical school, but I was working in the world before I went back to school, and I went to see a psychic who didn't know the first thing about me. And she said, you have a very healing way about you, and you have to remember that healing is more than just taking care of someone who is sick. And those words have stuck with me because there's a lot of healing we all have the ability to do, and that has really kind of embodied my approach to medicine. It's not just taking care of someone when they're sick. It's trying to help keep people healthy, but health goes way deeper than just a set of numbers that come from a laboratory or a count of eggs that we might see on an ultrasound or an embryology report. It's about the health of the spirit. It's about the health of the soul, and I really feel very strongly with that. We can really make the world a special place just by doing the things we do and being the people we are. E. Romero, that was a brilliant thing to share. Thank you. Sweaters asks, are there stim meds or ovulation induction meds that are acceptable to take if you're still breastfeeding a toddler? My periods are regular, not ready to wean, but I'm ready to try to conceive again. My answer to that is no. So could you get pregnant while you're breastfeeding? The answer is yes, you can. I don't recommend it because it becomes a challenging environment to be able to provide enough sustenance for the baby on the inside, as well as for the baby on the outside. So usually we find if someone is breastfeeding and they become pregnant, we usually recommend that they start to wean. Unfortunately, all of the medications, pardon me, all of the medications that we use for ovulation induction will have an effect both on milk supply and will transfer through the milk to the baby and may have an effect on the baby. So we do not typically do ovulation induction in someone who is currently breastfeeding. And that's really the reason why. It's because of the medications. But in general, pregnancy outcomes are higher if you're not breastfeeding when you get pregnant, and that's the same across the board, whether it's through fertility treatment or even spontaneous pregnancies. We'll be here for about another 20 minutes. This is Fertility with Fink, live from Pensacola, Florida, where I work at the New Life Fertility office here. I'm a fertility gynecologist. We also have an office in Mobile, Alabama, and in Panama City. And I work with my wonderful friends also at the Missouri Center for Reproductive Medicine, MCRM, in St. Louis and in Tulsa. We are part of the First Fertility Network, and if you are watching tonight, I am very honored that you would be here. We're back here every Tuesday evening at this time. Throw your questions my way. We've got a bunch of different feeds here. This is New Life Fertility's Instagram. We've got Facebook, a bunch of different Facebook and LinkedIn and YouTube profiles right here. And this is my Instagram at Randy Fink MD. And that, Mallory, would be a good place to message me. If you have a question and you can't seem to get it in tonight, or you just don't want to type it in and share with everybody, feel free to also email me at askfertilitywithfink at firstfertility.com. That's another way, but Mallory, please message me on Instagram if you would. Okay, let's see what else we got going on here. Can you do a medicated cycle with a trigger for an FET? And the answer to that is no, because talking about two different things that are kind of going on there. One is, well, a medicated cycle is where we're giving you all the estrogen and the progesterone that you need. Whereas a trigger shot is used in a natural cycle to get your ovary to release an egg. Because when you've made that egg, then you've made your own you've made your own estrogen. And when you release that egg, you have made your own progesterone. So triggering is designed to help control the timing there, but that timing control is timed exactly from when you start your progesterone in a medicated cycle. So using a medicated cycle means you wouldn't do a trigger shot because you shouldn't actually be making an egg. We don't want you to make an egg because then your own egg will start to interfere hormonally with what we're doing in that medicated cycle. But good question there. Let's see what else we got going on here. G. Amanda, howdy. SB Charles, haven't seen you around for a little bit. Nice to see you here this evening as well. Oh, let's see if we had, there was a couple of other questions that I received by email. So, and I looked at it right before I logged on here. So let me try to remember exactly what was. We talked a little bit about the rapamycin, about the sirolimus, and where I think we're headed with that. Now, you may also know that there's a medication that's called tacrolimus, which is also known as Prograf. Tacrolimus is another medication that is used at the time of, is another immune modulating medication that's used at the time of embryo transfer, specifically for people who have a history of implantation failure. In other words, they've placed embryos in that should have stuck, but didn't. So one of the thoughts there is that the body may be creating an immune response that's trying to prevent you from getting pregnant. It may be trying to reject your embryo. And so what does tacrolimus do? Tacrolimus helps to turn down some of the immune response that's associated with rejecting things like a solid organ, like an organ transplant, or in this case, things like a pregnancy. Sirolimus works a little bit differently. So one of the things that happens is that as we age, or as we mature, as I prefer to think of it, that maturation results in cells start working a little too fast. The portions of our cells that make our proteins, our ribosomes, that's a part of the cell, makes proteins. It all starts to work too fast. And when things start to work too fast, it starts spinning too quickly and things start messing up. Your body starts making errors. So what sirolimus does, or rapamycin, and it said that speeding up process is associated with aging and with the way cells may prematurely age. What sirolimus does is that it taps on the brakes. It taps on the brakes and it just slows things down, and it may allow these processes that make things like stabilizing our eggs, the DNA in our eggs and the way these eggs will function in the body, tapping the brakes slows it down and may improve the egg quality. So that's how those two things work. But sirolimus and tacrolimus are both different medications, even though they're both immune modulators in some way. So that was a question we had here. Hey, Shadia, nice to see you this evening as well. So what are you guys doing to celebrate Mardi Gras? Anything? I hope wherever you are that you bring your own parade with you because you are that party, you know? And if you're in a part of the country that doesn't celebrate Mardi Gras, if it's not a thing, well, then maybe just take a minute to kind of celebrate life and all those good things that life has handed your way, all those things that we often underappreciate, things that we take for granted. They talk about stop and smell the flowers. Flowers smell pretty good if you give them a chance. Go outside, listen to the birds, because the birds, they talk to you. Just hearing them tells you what a really wonderful, amazing place we live in. Watch the sunset, watch the sunrise. I don't like to watch the sunrise too much because I actually really like to sleep, quite frankly. But just appreciate all those little things that are out there, because the world gives them to us as little gifts, and too often we're so busy, we just don't have time to unwrap those gifts. And this is my 2 cents worth. Oh gosh, let's see what else we want to talk about. I got another question that had to do with DNA fragmentation in sperm. And the question was, so let's talk about what DNA fragmentation is. DNA fragmentation is when the genetic component of the sperm starts to unravel. And that unraveling of the DNA in the sperm eventually means that the sperm just may not function as well. It's not going to be able to fertilize an egg as well. So if we see a persistent abnormality in, let's say, the way the sperm look, we might start looking at DNA fragmentation. The question was, is there a way to look at DNA fragmentation without having to do the test specifically for DNA fragmentation? And the answer is yes. As part of a normal semen analysis, so at MCRM, we do a test called the HALO test, which looks at DNA fragmentation really in every detailed semen analysis. So we get that answer. But there's something called a sperm progression score. First question is, why does this even matter? It matters because in folks who might otherwise consider doing something like ovulation induction with, let's say, timed intercourse at home, or doing an ovulation induction with an IUI. Well, with higher degrees of DNA fragmentation, we know that those methods really are far less likely to work. Even if all other parameters are normal, let's say a normal sperm count, maybe a morphology issue, but with a high degree of DNA fragmentation, doesn't matter how good the ovaries are, how open the tubes are, the odds of an IUI being successful are very, very low in that scenario. So that would be a tool by which we would counsel someone to say, you really are going to do better with IVF because the IUI is just not likely to work. So is there another way to test it? And the answer to that is yes. In a standard semen analysis, we have something that's called a sperm progression score. And a progression score is scored in number 1, 2, 3, or 4. 1 means the sperm just aren't really moving. They may be twitching, they're just not going really anywhere fast. 2 means, well, some of them are moving, but still they're not doing very well. 3 means most of them are moving, and 4 means, well, almost all of them are moving. And so 3 and 4 is associated with a low degree of DNA fragmentation, whereas 1 and 2 are associated typically with higher degrees of DNA fragmentation. So if your semen analysis says that there's more 1s and 2s, it means that that specimen is probably not going to do as well with timed intercourse or with IUI. Whereas if you have a 3 or a 4, that suggests that that specimen will do better. So I hope that answers the question about DNA fragmentation, and are there other means of testing it other than having to do an expensive, potentially expensive fragmentation test? Answer there is yes. Shania says, can you talk about progesterone pills during the first trimester post miscarriage? Well, not sure what to make of that. So sometimes when folks have a history of miscarriage, that when we find out you're pregnant, we might give you a little supplemental progesterone to use. Now, I have to say, and I do that as well, but I have to tell you that that's really witchcraft, because a low progesterone does not cause an unhealthy pregnancy. And let me repeat that. A low progesterone does not cause an unhealthy pregnancy. Rather, an unhealthy pregnancy typically causes a low progesterone. So let's say you spontaneously conceive and somebody checks your progesterone and the level is, they say, oh, this isn't high enough. Well, that suggests that there may be, it's not a your body issue. It's more likely it's the pregnancy itself. So, nevertheless, we often give people who have had miscarriages some extra progesterone. Why do we do that? Just seems like the right thing to do, but it may not be really grounded in science. There are some folks who say, well, my doctor gave me some progesterone, and that's the only reason that my pregnancy continued. And I would say, now, how do you know that? How do you know that the pregnancies before weren't normal pregnancy, weren't, abnormal pregnancies, and they ended, and this pregnancy happened to be normal? So we do it, but it's not something that is really grounded in much science. It's extrapolated from the fact that in IVF, in a medicated cycle, we're giving you all the progesterone that you need. Or, in a natural cycle, we're following those progesterone levels because that makes those progesterone levels make a big difference. As far as using progesterone post miscarriage, well, there's nothing really specific I can think of. So I'm not really sure what the situation is there, but I would be happy to talk to you about it offline if you'd like. And you can message me at Randy Fink MD. That's my Instagram right here. Midgie asks, as a donor egg recipient, should I ask the clinic that I'm working with what stim meds they had the donor patient take? I'm a bit concerned about quality, as I've had 12 before without success. Well, so here's the thing. They may not have access to that information. And even if they give you that information, you may not really know how to interpret it. So what we're talking about here, when we were talking with Mallory a little bit before about hyperstimulation in the donor egg world, I think you just have to have some trust in the donor egg banks, and depends on where you get them. So some practices have their own donor egg systems, and each practice works a little bit differently with that. Some, quite frankly, are better than others. But, in most cases, let's say that you get a cohort of maybe 6 eggs. You get those eggs and none of them survive the thaw. Well, that's not a normal thing. And in most cases that egg bank is going to replace those eggs for you. And let's say that you get another 6 eggs and none of them survive the thaw. It's time to start thinking about, well, maybe I should either pick a different donor or potentially pick a different bank. But they ought to consider giving you your money back for that too, because, well, assuming the lab was thawing them properly, that would really be abnormal that none of your eggs survive. Well, what happens if those eggs just don't, you get no blasts out of them? You get maybe a couple of day 3 embryos, but then they stop growing. Well, that too suggests that there was an egg quality issue. So some of that, I think, Midgie, has to do with, well, what happened with those 12 eggs before? Did they grow to embryos? Did they make embryos? They just didn't make blasts, or did they make blasts and you did transfers, but you didn't get pregnant? So, there can be some nuances to that, but more often with hyperstimulated eggs, you have to think about, well, they may not survive the thaw, or they just simply may not fertilize. And if they fertilize, they may not grow to blast. I usually recommend that with donor eggs, you should, there are many practices who will allow you to do day 3 embryo transfers. I don't do that with donor eggs. You really should be getting blasts so that you know exactly what it was that you purchased. Again, my 2 cents worth on that. But in my practice here, we really don't do day 3 transfers for the most part anyway, because we know that when those embryos grow to blast, they have a higher probability of being able to get you a baby. And what we want is to get you a baby. So it just gives us a little bit more information over, about, the quality of the embryo and what was made for you. Let's see. Hey, Faith, Hope, Love, Warrior, Fertility. It's a mouthful, but thank you there. Cliz M, howdy, and T Bienvenida. Half survived to blast. So Midgie said half survived to blast. So you did transfers, and none of them gave you a live birth. I'd have to kind of look at that carefully, but that suggests to me that those were probably good enough quality eggs. So, but it makes me wonder. Well, how old was the donor? And they made blasts, but why didn't any of them make a baby out of 12 eggs? So you got half survived. 12, that means you got 6 blasts. I would expect that should have given you a pregnancy. So just statistically speaking. Folks, we're all out of time tonight. Again, a very special thank you for being here and a happy Mardi Gras to everybody. Happy Fat Tuesday. We'll be back again next week at Fertility with Fink right here, 5 o'clock p.m. Central Time, 6 p.m. on the East Coast, 4 in the mountains, and 3 on the West Coast. Remember, this fertility business is not the book of your life. It is just a chapter. And what are we here to do? We're here to rewrite it. And let's do that together. So until then, every step forward with love, not enough love in this world. Every step forward with kindness to other people. Do those random acts of kindness, please. And every step forward with hope. Because tomorrow is a new day, my friends, and it is full of all new adventures. Until next week, Dr. Randy Fink, thanks for being here. Good night.